Okay, so we'll just get started. I will give credit to ChatGPT for the title of this talk because I could not think of anything, but I didn't use ChatGPT for the talk itself. So neither Dr. Kukull or I have any financial disclosures. And oh, wow, this is loud. Okay, so the point of today, right? We want to make sure you guys are able to describe the clinical presentations of malaria, also explain and interpret the appropriate diagnostic approaches for malaria, and then basically know how to treat uncomplicated and complicated and severe malaria, including management of the complications. So I'm going to kind of discuss one of the patients that Dr. Shaw mentioned because she was kind of the impetus. So it's not going to be a huge surprise. Okay, so we had a 30-year-old female. She actually presented on January 31st with a 1-week history of fevers, headaches, and fatigue. She actually had just returned from Sierra Leone with her family on January 23rd, where she was there for about a month, visiting family, and she actually had been in Nigeria a few days before entering Sierra Leone. No one in her family took malaria prophylaxis. And actually, by the time she came to us, her 2 sons and her husband were already admitted at Legacy Emanuel and Randall's with malaria. Her husband was actually admitted that day upon the urging from the pediatric ID physician who said, "You look horrible, you should go to the hospital and go to the ED." So unfortunately, she did not want to start anti-malarials without confirmation of a diagnosis, although I feel like all of us think the pretest probability of her having malaria was really high. So if you could see, she was febrile in the ED, tachycardic, but she was pretty, her blood pressure was fine and she was setting fine in there. She wasn't anemic. She was slightly thrombocytopenic with a platelet count of 128. Her kidney function was fine. Her ALT, AST were mildly elevated, and her total billing was 1.2. So she showed up to the emergency room in the evening. So the parasitic smear was drawn in the evening, and so she was sent back to her family's room with the anticipation that we're probably going to start therapy here in the very near future. So her malarial smear returned positive for P. falciparum with really pretty low parasitemia. So we asked her to return to the hospital. And as you can see, her vitals relatively stable, although a little bit hypotensive. As you could see from a lab standpoint, she was a bit more thrombocytopenic with a platelet count of 53, and her LFTs were up a little bit. So we started her on artemether, lumefantrine, and I'm just going to refer to it as Coartem moving forward. And so what we did was we actually ordered a parasite smear for the following morning. So if you can see the top 2 slides, that's her smear from January 31st. And that's kind of, you don't really see a lot of these small rings that you can see kind of in the red blood cells in the top right smear. And then you can see on the bottom 2 slides are her smear from the February 2nd, and you can see a heck of a lot more of these little rings. And so she was actually, it was read as 19% parasitemia, which is quite a bit. And so that led to her actually being transferred to the ICU to start IV artesunate. She actually required a short stint of norepi because she had a little bit of shock. So she got her 3 doses of IV artesunate with a good clinical and parasitic response, and then we transitioned her to Coartem. And I just kind of trended her labs for you while she was in the hospital, so you could see she definitely was more anemic. I did not put her platelet counts, but she was still thrombocytopenic. She developed an AKI, her total billing went up, but you could see that her parasitemia responded quite nicely to the artesunate and went from 19% to 2%, which we expect to see. But all of her lab abnormalities are very consistent with what we see with severe malaria. Still going, because unfortunately she got readmitted on 2/22, so about 2 weeks after she was discharged with anemia, which was actually thought to be delayed hemolytic anemia related to artesunate. She was supported and clinically, and she received 2 units of packed red blood cells, and her repeat parasitic smears remained negative. And then you can kind of see kind of the trend. She did get CBC before she came into the hospital, and her hemoglobin was pretty stable. Her creatinine continued to improve, and her total billing was also coming down from her hospitalization. But you can see kind of the labs were consistent with hemolytic anemia, and her parasitic smears remained negative. So let's talk a little bit about malaria. It's still a global problem. As you can, you can see there was in 2023 per WHO, there were still 263 million cases in 83 malaria endemic countries. You can see the bulk of the infections occur in the African region. Greater than 90% of cases as well as deaths occur there. Most of the cases in the US, which are roughly about 2,000 cases per year, are imported. There are rare cases of local transmission, like, mosquito bites somebody who was infected and then maybe goes on to infect somebody else. And 95% of the US cases actually did not take appropriate chemoprophylaxis for malaria. So there's 5 species out there that causes human infection. Plasmodium falciparum, we're probably going to focus a lot more on that, but Plasmodium vivax, ovale, Malaria, and Knowlesi. The reason we are so not obsessed, but we worry a lot about falciparum is because it's associated with high mortality. So I'm going to give credit to Dr. Kukull because I borrowed this slide from one of his presentations, but this is kind of a nice way to see kind of where the different Plasmodium species kind of, where you can see most of it in the world. As you can see, the bulk of the infections are actually in Africa, but then you can see vivax elsewhere, and we'll kind of leave it at that. I'm not going to try to do geography right now, sorry. Okay, so this is kind of that fun life cycle slide that comes up periodically that you guys see and probably ignore. But essentially, right, malaria, there's the life cycle in 2 hosts. There's mosquitoes and then there's humans. And so really, right, the mosquito will inject the sporozoites into the human, and then it goes into the liver, and that's kind of where it matures into schizons. Sorry, I was just asking Dr. Kukull to say that word before. And then, it ruptures and then releases the merozoites, which then go on to infect the red blood cells, and that's where it does its, undergoes the asexual multiplication. And so, as you can see from there, it will then turn into the trophozoites, which can then go into the schizont, which then ruptures, and then kind of goes on to reinfect. Or then sometimes it can go into the gametocytes. So really kind of this blood stage part in the right lower corner is responsible for kind of the clinical symptoms that patients have when they present with their malarial symptoms. So these gametocytes then will go on and be ingested by the mosquito when they bite somebody, and then it goes on to turn into zygotes and then essentially multiply. And then these ooconites turn into oocysts, which then invade the gut wall of the mosquito's stomach, which then eventually makes it into the salivary glands to then, rupture and then get more sporozoites. One thing to kind of remember is the hypnozoites can persist in liver for vivax and ovale in a dormant stage, so we can see that cause relapse. Down the road, it doesn't have to be months, it can be years. So when should malaria be on your differential? Really, any return traveler or any patient with a history of travel to a malaria endemic region with fevers should always be on it. So then how does somebody with uncomplicated malaria present? Unfortunately, it's pretty non-specific symptoms, right? It's like flu-like illnesses. It's fevers, myalgias, nausea, vomiting, headaches, diarrhea. You may have remember learning kind of about these malarial fevers where you kind of see the cyclical fevers, right? You could see it every 72 hours, every 48 hours, and then those are kind of associated with certain species. So with vivax ovale, you can have fevers every 3rd day, so there's 48-hour kind of interval. But the portent is the malaria, which is every 72-hour interval. Now with falciparum, it's said it's potentially a 48-hour cycle, but really it's more common to be irregular or continuous. I don't think I've ever had a patient with falciparum malaria tell me that they have fevers every 48 hours. They're having fevers every day. And as usual, you may not see the typical fever patterns in the early stages of infection. So just because they don't have that cyclical fever doesn't mean they don't have malaria. So what do we see with uncomplicated malaria from a lab finding, right? You can see anemia, thrombocytopenia, elevated bilirubin, LFTs, elevated LDH. They can have a normal white blood cell, or mild leukocytosis or leukopenia, and kind of we saw that with our patient, right? At least when we thought she was uncomplicated based off her parasitemia, she had all of those lab findings. You would expect to see a normal glucose with uncomplicated malaria, but not with severe malaria. So then how does one decide if somebody has severe malaria? There's very specific criteria. So they have to meet one or more of the following criteria. So, right, I mean, she met it based off her high percent parasitemia right there. She was greater than 5%. We worry, right, impaired consciousness, seizures, concerns for potential cerebral malaria there, if they're in shock, if they have pulmonary edema, acute kidney injury. So if it's like greater than 3, DIC, and if they're jaundiced, that can't be the only one. Jaundice has to be with something else. And sometimes they do that based off the degree of parasitemia. Usually it's like 2.5% for falciparum, or if they're severely anemic. And then we're going to kind of go into diagnostics, and I'm going to leave this to Dr. Kukull because he is much better at this than I am.
Yeah, so luckily diagnosis of malaria is relatively straightforward and has been around for a very long time. The classic is our thick and thin smear, so just microscopic examination, which luckily enough is extremely low tech, and most labs are able to do it, and it's for the most part you can get to a specific species as well. We do actually, in conjunction with this, rapid diagnostic tests, which is antigen testing. It's not much unlike our COVID antigen testing. Lateral flow assay. Those are done in conjunction. If you order a blood parasite here, so that in the EDTA tube, it can be ordered stat, and both of these tests will be run. If in the case that the rapid test is positive, the smear will no longer be considered stat. It will still be done in a reasonable time frame. The rapid diagnostic test can detect falsip versus other or negative. And PCR, I'm not going to talk much more about, but it is helpful in some rare occasions. Say you have extremely low parasitemia, so you just have like one ring and 3 paired collections of smears. Can't really get to a species that way if you want to rule out falsip. This can help to further confirm the diagnosis. There's also a lot of overlap between Vivax and Ovale. Not a lot of times do you have like a travel history that's consistent with like overlap of both potential species, but it does happen, and PCR can help identify which exact species. I guess we had one recently last year that was either malaria versus Vivax, Malaria versus Vivax, but the patient was in, I believe, Venezuela, which much higher incidence of Vivax, and PCR confirmed Vivax. So just knowing something about the history obviously helps narrow it down quite a bit. PCR can also be used in very limited settings. We don't see enough malaria here. This really comes up with like detection of drug resistance genes. They can do that at the CDC as well. And it is a higher sensitivity than the smears. So in the case that you still have high suspicion, it can help rule out, but generally clinically much more useful just to have a rapid diagnosis and good estimation of parasitemia. So this is an example of our malaria Binax now. It's just a lateral flow antigen test. Specifically, it has 3 different potential bands there. You see 1, 2, 3 control band, just like a normal COVID antigen test, and then 1 antigen that's specific for falciparum, and then another one that's present in all species of malaria. So positive for falsip, or you can also have mixed. So if you have all 3 bands strongly positive, then it could be a mixed case as well, which is important to note because, of course, if you have one that has hypnozoites plus falsip, you don't want to treat appropriately. And also falsip can be kind of overwhelming infection, and you might not see the intermediate forms that are more characteristic for Vivax and ovale. So let me see. Yeah, and it certainly does not eliminate the need for microscopic examination. It's important to see morphology and estimate the parasitemia, which this obviously doesn't. And it's also not as sensitive as the smear or PCR. So this can also be negative but have a smear positive. That it doesn't mean it's refuting the smear or specimen mix-up or something like that. So just a little bit maybe more exhaustive than one would like, but I think everyone should know some basics about how the smears are made and how they're interpreted. Again, this is the smears. Blood smears are a very simple, quick diagnostic, available stat. Again, it's called smear blood parasite from the test table. And what we do is we make two thick and thin smears. Ideally, there should be 3 sets submitted by you all 12 to 24 hours apart to rule out. The first one positive, if it's stat, will be considered stat. If you keep ordering stat on additional ones, they won't be stat unless you talk to the lab that you want everything stat read as well. But so again, EDTA tube. The thin smear is just one drop smeared across. It's smeared across the glass. Methanol fixed and Giemsa stained. Giemsa is important because it also, for blood smears, because you can see additional details within red blood cells that you can't with other stains. And thick, it's pretty rudimentary. It's just one drop of blood that dries on a slide. It's roughly 4 microliters, and that's important due to the below calculations. That's just hemolyzed, so you're left with a background of parasites and white blood cells, just using basically water to hemolyze the red blood cells there. So you're just left with the background of whatever's left. So in the thin smear preparations, we actually have these grids that we use with our microscope to estimate the fields of how many red blood cells we're looking at a time. As you can see, these very sort of characteristic ring forms. They're easy to spot. One parasite in a red blood cell is counted. If you have multiply infected, it doesn't count as double. And also, gametocytes do not count either in this case. But in the case of falciparum, what we're going to see most is these ring forms anyway. And just based off that, we can do a rough estimation of parasitemia. So that's what we're looking at, and that's the most accurate quantitation. I mean, theoretically, you can do it with a thick smear, but what is kind of the use for this very rough estimation, when the thin smear will be much more accurate. And I've reviewed hundreds of these, and I have never seen a thick smear positive when a thin smear is negative. So it's just kind of limited utility there. They're still pretty to look at and see what you can see, but I think for the morphology and accuracy of parasitemia, the thin smears are where it's at. And it is relatively easy to diagnose, and hopefully everyone in this room would be able to identify a ring form within a red blood cell. Getting to the species is much more complex and takes quite a bit of experience to get comfortable with it. But in my world, even my practice of pathology, I like to keep things simple. I'm certainly a lumper rather than a splitter, and just try to keep in mind like what is important, what isn't important. If we're trying to rule out falciparum, let's just stick to the basics. So for the infected cells in falciparum and Malaria, they infect more mature red blood cells. The red blood cells seem to be smaller. Ovale and Vivax preferentially infect reticulocytes, so they're larger often. Falciparum and Malaria also have smaller rings, and some key features of falciparum seen here on the top there is like double chromatin dots, some refer to them as headphones, multiply infected red blood cells. So you can see multiple rings in one. Applique forms, which are basically, you see there on the edge there, just that the little dot like pushed to the side. That's much more seen in falciparum than the others. And the legendary banana gametocyte that shows up on every board exam, but is never seen. But I'll show you a picture of one of those, but that's diagnostic because the other gametocytes do not look like that. I guess the biggest pitfall for falciparum, have in mind your travel history if you're looking at these, because babesia can look almost identical. There's supposed to be some key features that aren't don't overlap. Like babesia has extracellular forms as well as like more visible like clearing vacuole within the ring. But I have seen cases that are morphologically identicals. And this isn't like a biological coincidence. They are actually related, apocomplexia and parasites. So they are actually related. It's that'd be a very strange coincidence. For malaria, like there are several additional forms. Don't need to go into it here, but this is what I use for board exams or like tech training. Malaria is known for all the forms I refer to as like the B, the very first on the left there, having like you imagine just sort of a bird eye with a beak, bands, basket forms, and soccer balls. But again, getting into a little bit of the weeds here. As far as like the larger infected red blood cells, that are vivax and ovale, and the ring forms are also respectively larger. Distinction between these can be quite difficult, and we have to look at quite a few forms. I guess importantly, I didn't mention that falciparum, these intermediate forms that you're seeing below the falciparum, like essentially are not, they do exist in falciparum, but they're just not seen on the smear. So if you're seeing a lot of these intermediate forms, you already know it's not falciparum, but of course can be, falciparum could still be there as a mixed infection. That's good. I'll go through a couple just morphologic appearances here. Again, the thick and thin film here. The thick on the left, no red blood cells. You see tons of parasites. Great. Like, count your white blood cells and try to estimate, or just look at the thin film and have a much cleaner estimation of what you're dealing with, and come to a good quantification of parasitemia. I like accuracy in this case. I think the thick film is just too rife with variation for estimation of parasitemia. So again, this could be falciparum. This could easily be babesia as well. So you're seeing many of these. So high parasitemia is important. Small ring forms, multiply infected, little headphone forms, applique forms, meaning the dots pushed to the side, and minimal extracellular forms, which would be more in a babesia. If someone's like, where'd you travel? I mean, I was in Connecticut. It's like, okay, it's not falsified. Oh, there it is, the banana gametocyte. You're lucky enough to lay eyes on one of those. I maybe I've seen one, but it's not usually what gets to the diagnosis. Vivax, again, affecting reticulocytes preferentially, have larger red blood cell forms. They do have some of these Schuffner dots or stippling, and various intermediate forms you can see. This isn't a good slide for the amoeboid forms, but the red blood cells also kind of lose their cytologic structure. Like their cytoskeleton is just also kind of manipulated, so they just look kind of wacky, like blobby. They will like wrap around other adjacent red blood cells. These are all soft morphologic findings and certainly not totally diagnostic. Malaria showing a smaller red blood cell infected, and this is a band form. And then ovale, it's pretty cool when you can see it, but like a fimbriated form. They also lose some of the integrity of the cell membranes, become fimbriated, but also just on one side. It's important to look at the adjacent red blood cells, because obviously that could be just if you're seeing all the red blood cells smeared adjacent to it, like that doesn't count. It can't be created if they're dehydrated, like red blood cells look also spiky. But this is a great comet form with a large ring form in the middle there. And I guess that's it for my section here.
Can you say something about the timing of when the smears are read, because they're not really
I mean, I'll have to check with the lab for their exact business hours, but not read in the middle of the night now. Yeah.
But the antigen will be done at night.
The antigen will be done at night.
But from like a parasitemia, degree of parasitemia, we won't know that until the day.
Yeah.
Yeah, and so typically the smears, if you're going to get them, they have to be there like in the morning, or I think I want to say before 3 p.m., right? If you want them read that day. So that's kind of the issue as well. So just some logistic things to know from that standpoint. So just going to go into treatment. Right, so general guidelines for treatment of uncomplicated malaria is really to know where their travel history was and where they were, because where they were will actually help guide the therapy. And so different Plasmodium species actually, of course, require different courses of therapy. And so if your patient actually took chemoprophylaxis, you're not going to use that same drug to use for treatment of uncomplicated malaria. And we want to make sure they get repeat blood smears daily, because you want to document clearance of their parasitemia. And we'll mention this multiple times, but Vivax and Avele, you require further treatment to prevent relapse in the future, and we'll talk about that. So this next slide's pretty busy. I don't expect you to remember any of this. Well, I remember maybe a few things, but I will tell you that I look this up all the time as well. Okay, because I'm not going to remember. Well, I should, but I don't always remember the dosing. So I have to look it up in terms of timing, right? So if you have a malaria, uncomplicated malaria from falciparum, or you don't know what the species is yet, I think it depends on where they were. And so how they differentiate it were they in an area where it's chloroquine susceptible versus resistant or unknown resistance? And so they kind of go based off kind of location. So as you can see, chloroquine susceptible, you can either use chloroquine or hydroxychloroquine. But when we talk about chloroquine resistance, the drug of choice is going to be Cortum, and then Malarone or atovaquone proguanil, and then they go into quinine sulfate plus doxy or clinda. They also recommend tetracycline either, but honestly, it's not very well tolerated, and it's a pain in the butt to get, so I didn't even put it on the slide. And then they recommend mefloquine as kind of your last choice. So when we talk about mefloquine, it's kind of like if you have no other options, then you're going to use it, more so just because if your patients have a neuropsychiatric history, it's kind of contraindicated, or people don't do well on mefloquine, and then they actually recommend against it if you feel like if your infection was obtained in Southeast Asia. And so this is kind of, you'll see this is a similar theme. Okay, so these are going to be the drugs you're always going to use with all of your different species, just kind of depending on where they were, right? So as we can see with Vivax or Avele, really, if it's pretty chloroquine susceptible, except if you're in Papua New Guinea or Indonesia, you can use chloroquine and hydroxychloroquine, and if not, then it's going to be those same 4 drugs in the same order of preference. Because there's a dormant stage in the liver, once you do treat their acute malaria, then you're going to want to give them treatment for anti-relapse. So that's either going to be primaquine or tafenoquine. And we don't want to use primaquine in patients who have G6PD deficiency. So that's probably going to be one of the labs that you're going to want to know about and get when a patient is diagnosed. We don't see a lot of malaria or Nolesi, and as you can see, it's pretty chloroquine susceptible, so you can actually use any of those drugs, but no one is going to fault you if you're going to try to use Cortum. Okay, I think let's talk a little bit about severe malaria, because that's kind of where we get really excited. Right, treatment for severe malaria, you have to treat promptly and treat aggressively, regardless of whatever the malaria species is. It's going to be IV artesunate, and you're going to give it 3 doses, about 12 hours apart. Now, IV artesunate was actually FDA approved in 2020, even though it was being used elsewhere in the world before that. So I know. So sometimes IV artesunate is not always available, and so you can use oral therapy to kind of buy you time while you're getting IV artesunate. So before 2020, you had to call the CDC malaria pager, talk to them, and then if they approved it, then it would be sent from whatever stockpile. Our stockpile came from Seattle. And so in the time, then we would use one of these drugs to kind of buy time, right? So Coartem is still going to be your first drug of choice because it has a fast onset of action. Then you can use Malaria, then you can use quinine, but I'd be careful with this because it can prolong your QTC. Methylquin, once again, only if you're stuck and have nothing else available. You don't want to use clindamycin or tetracycline alone because that's actually pretty slow acting, so it doesn't take effect until over 24 hours. And it's really not effective for treatment of severe malaria alone. And then, of course, you shouldn't use the medication that was used if they actually took chemoprophylaxis. And so once you have IV artesunate available, you're going to go ahead and start it and then stop the oral therapy. This is kind of where we want to make sure that they're getting a set of parasitic blood smears every 12 to 24 hours until you see a negative result. Because we actually use that to determine when you can be done with IV artesunate, like if you can be done with it after 3 doses versus you need a little longer, and then when we want to transition to oral therapy. So, you know, if your parasitic smear, if your parasitemia is still greater than 1%, you want to continue artesunate daily until their parasitemia is less than 1%, and you never want to give it for more than 7 days. If it's less than 1%, then you can transition to oral regimen. Same drugs we talked about, same order of preference. Coartem is always kind of the drug of choice. And you know, if you did use Coartem or Malaria before you started the IV artesunate, you can go ahead and use that again to finish the course, but you don't want to like say, oh, you got 2 doses before, so that'll be included as part of your course. You basically just start over and give them the full course. And the reason that we transition to an oral regimen is because IV artesunate has a pretty short half-life. It's great at reducing the degree of parasitemia pretty quickly, but it may not necessarily kill off all the parasites that are there or in kind of later life cycles. So you want to make sure that you are basically killing off all the parasites to try to minimize the risk of relapse. And then, of course, there is that if they're unable to tolerate PO medicines, I'm sure you can get IV artesunate daily, but no worries. ID will always be there to help guide this because this is all the malaria drugs are ID restricted, so you need this involved anyways. Okay. So one complication that we see, right, there, you know, with complications with like severe malaria, especially with like cerebral malaria in kids, they can still have kind of these long-lasting neurologic complications as they grow up. Sometimes you can see like a ruptured spleen, you know, related to, I think it was Vivax and like recurrent infections. But one thing that we tend to see, which is rare, but I mean, we saw this with our patient, right, is delayed hemolytic anemia related to after artesunate. And so really what they think is the higher parasite density seems to increase the likelihood of a delayed hemolytic anemia. And actually, they should have weekly lab monitoring for up to 4 weeks after. Unfortunately, our patient did not show up every week to get her blood drawn and kind of required constant reminding. And, you know, blood transfusions may be needed to support this. And before there was some thought about exchange transfusion as an adjunct procedure, but that's no longer recommended because it wasn't really shown to be effective. So just some take-home points, a lot. So remember to always keep malaria on your differential for fevers and return travelers, right? You want to ask a pretty extensive travel history and not just go back like 6 months. You want to know where they've been for the past few years, right? Because you could potentially have a relapse depending on where they were. P. falciparum associated with high mortality. We talked about the Vivax novelle. Microscopy is the gold standard for diagnosis. And honestly, if you can only remember 2 malaria drugs, remember Coartem and artesunate, okay? And severe malaria needs to be treated immediately. So you wake us up. If it's in the middle of the night, we don't care because it's actually severe malaria is considered an IV emergency. Okay. And we will take any questions. I can see questions.
So if it's nighttime and you just have a positive antigen and they just have even like a slight AKI, that would be an indication to start IV artesunate, because that would be all under severe malaria.
No, so if it's a slight AKI, like their creatinine has to be over 3.
Over 3. Okay.
Yeah, so there's kind of thresholds there. So a creatinine over than 3, like a total bilirubin over 3,
So
Um,
if they had disability over due, that was the only thing they had, you would probably start.
you would start one of the oral agents, but you would still call us
Yeah.
for that.
I want to just emphasize what Dr. One just said about asking a complete travel history. It's the two people that I have traveled to Kenya with, and done medical outreach have had, one of them had a diagnosis 9 months after returning, and another 4 or 6 months after. And fortunately, both of them, what was happening. And then also, I mean, Gordy can probably speak to this as well, but what we do here, like if you do an international medicine, what we do here is potentially very different than what we do. Like we do not do repeat smears when I go to Kenya. It's like we treat them until they can take the oral meds, and then they go on the oral meds, and that's it. So just acknowledging that if you do international medicine, then you can learn kind of from that country and how they're treating the resource for environment. So.
And I will tell you that if a patient took chemoprophylaxis, that can delay their onset of symptoms for months, right? Because they took it. Chemoprophylaxis, I would love to tell you it's 100% effective, but it's not, which is why we also recommend insect precautions, right? You know, wearing appropriate clothing, spraying your clothes down, insect netting, all of that. You know, and also with travel, because I did have another patient with severe malaria, and who he traveled with his dad, but his dad was fine because he actually got doxycycline when they were in Africa for tick bite fever, so he was kind of protected. So, you know, everywhere, you know, they can readily, because it's so common in the endemic regions, they can just be like, I think this is what it is, I'm just gonna take some medicine for it, and then be done. Yes, Sam and then Colt.
So, whenever the wife represented with the hemolytic anemia, the husband also represented.
Yep.
From both. I understand that part of his recurrence was because of like incorrect dosing of his Cloritin after he left the hospital, but he picked up on the pharmacy is not what was prescribed. But in kind of reading about his recurrence, I also came across something about Cloritin being less effective in people weighing over 100 grams. And I'm wondering if that is common, and perhaps like should we have treated this patient differently from the start versus is that like less common?
So I think that's less common because I do know, I didn't mention that the husband came back. Because I mean, honestly, the entire situation was an unfortunate situation where it was like a situation where you wouldn't want them to be in, where the parents had to decide who was going to go and who was going. I mean, she had to stay because she needed ivermectin, you know, just trying to figure that out because the kids could be discharged. It's pretty rare. I know that Dr. Hong actually reached out to the CDC malaria person, and he was probably like, it probably was just underdosed and not necessarily ineffective, but we were going to treat it with something else anyways. But yes, Coartem is it's the first choice because of just the fast onset of action. Colton.
How frequently do you do CDC gene resistance testing? Is that something that CDC makes a call for? Or is it
So I'm going to say, I know I've never done it. I don't know, Ben, if you've ever done it. No, so I would say probably in those cases where you kind of have like ongoing parasitemia, like your patient isn't responding like you would expect them to, then you kind of worry about resistance. You know, yes, there is some increased artemisinin resistance kind of reported in some parts of Africa, and so they do recommend some other agents first, but we typically don't do that upfront. Yes.
There's a request online to repeat or summarize the questions.
Oh yeah, sorry. Okay, so Sam had asked, so the patient's husband actually was also readmitted because he had like a relapse recrudescence of his malaria. And in her reading, she found that Coartem may be less effective, maybe in those who weigh greater than 100 kilograms. And is that something that's common or rare? And I said it was pretty rare and probably unusual. And then the next question was surrounding how often do we do CDC gene resistance, and that's pretty uncommon. Gordy.
So, I don't know, comment question. Does anyone know where that rapid test was developed? So, I went to a pathologist's backyard in Portland, Oregon. He had a shed full of Anopheles mosquitoes. You wouldn't believe it. I don't know how he got this by the health department because they were all infected. He was studying the red cells as a model for diabetes, and then he developed that model. Now there's been many friends after that. That was way back in the day. I brought it to India. It was just that time we had to do the smear. So the villages, you don't always have a microscope. We brought one done. Village, but a lot of things it's not microscopes. That test really revolutionized. That was cool.
Yeah, Gordy was just mentioning he meets interesting people. And
Oh, why do we need Evans from West Africa? You lived over there how many years? Did you take prophylaxis when you lived there? So why do I need it and he doesn't?
oh no, Evan's gonna need it when he goes back.
I know.
Yeah. While you were living there? Sorry.
Well, I had malaria 3 times while I was living there.
Yeah,
But when I went back to take, I did have to get sort of.
Yeah, so people who live in endemic regions kind of develop an immunity to it. And then they actually lose their immunity once they leave the area. And so, you know, if you have not lived in a malaria endemic region, you know, your risk of getting malaria without chemoprophylaxis is pretty high and can be more severe. I think Luke and then Dr. Shaw.
Quickly, with the broad defunding of science, is there concern that CDC integrity has been compromised? And if so, are there the resources that you use for that guidance?
Sure. So the question was really kind of with the current environment, political environment, and kind of defunding how, I guess, reliable probably are the current sources. I will tell you that the current CDC guidelines that are up in terms of treatment was before this administration. And so I don't think that much has changed, and I think treatment probably will still be there. That is still effective. Was kind of joking, not joking, but we were surprised somebody picked up the phone when we were calling about the patient's husband, you know, on the malaria pager to see. So I think there's still a group. I mean, I think the infectious disease society is still pretty adamant, you know, about science driven, evidence-based driven medicine. And so if there's some slack there, I think the infectious disease community will pick it up just from what I hear on my group chats. Dr. Shaw.
I vaguely remember something about sickle cell being protected against malaria. How does that work?
Oh, God. Oh.
Sorry.
I vaguely, okay, sorry. Dr. Shaw just asked how sickle cell, he vaguely remembers hearing sickle cell is protective for malaria. And I also remember that vaguely too, but I don't, Ben, do you know that?
They sickle when it gets infected.
Yeah.
It's specific around people.
I would say I wish I could tell you that off the top of my head, but that sounds about right.
It's not the advantage is usually for the
The parasites also consume hemoglobin. The hemoglobin structure is odd. We have a challenge to consume it, and this is actually how chloroquine works well. I'm sure these molecules. It's less easy to consume.
Thanks, Ben.
I think the defunding may affect the vaccination that's now occurring a little bit more, but I know
Yes.
vaccines are not as effective, but I was just thinking that they feel that at least they're using, I forget the name of it, the lower effectiveness that's on they thought,
Yeah.
but they were saying they've noticed a lower rate of hospitalization because of it, like they can just use Florida mostly and not have to admit people as much, but it is like it's such a small population, so many kids. But I suspect that was, you know, they're asking us, like, we talk to people at the CDC.
Yeah, no, that's an ongoing issue in terms of global health and kind of with defunding, kind of what is, what's available and what's gonna, how things will be in the future. Maybe we'll leave it at that right now. Uh-huh.
One more thing we don't really touch on like there's a infection of this exceptional case going from less than 0.1%
Oh, yeah.
to 19% for one day, and I don't think that really speaks to like the virulence and replication of this organism, but more speaks to the ability of falsehood to sequester venules in the periphery that might not be well represented, and see this rapid dynamic change comparison to TMEM, and not necessarily just how quickly it's replicating, just how it's stored in the periphery is also part of the pathophysiology, cerebral malaria and whatnot. So,
Sorry for people on the call. Dr. Kukull was just mentioning, how we saw like a less than 0.1 parasitemia up to like 19% in a little over a day, and probably related to the sequestration of kind of how FELSIP can be in the venules, and how that's a pretty similar mechanism for cerebral malaria. Any other questions? Are there any questions in the chat? Cool. Okay, you know where to find us. Call us. Any concerns? That's all I got. Okay, have a good day.